Hello, I'm Peter Reichardt. It's my great pleasure to make this presentation on localized operable primary GIST tumors. Unfortunately, we cannot meet in person this time due to the corona pandemic, but at least it's my pleasure to give greetings to everybody wherever around the world you are listening to this presentation. Okay, regarding GIST, local therapy for localized tumors consists of a biopsy or excision of the tumor in any case where the tumor is more than 2 centimeters big. For tumors smaller than 2 centimeters, the guidelines give the option to do follow-up only, which means the patients have to undergo endoscopy in regular time intervals to check whether the tumor grows or not. But most patients decide to get the tumor excised even if it's smaller than 2 centimeters. Interestingly, sometimes we have second opinion requests from patients who have a tumor of, let's say, 15 millimeters, and they say they would have been advised to wait until the tumor has grown up to 2 centimeters before it's resected. That is obviously not true. So also smaller tumors can be resected, but follow-up is an option for tumors below 2 centimeters. An exception are any potential GIST tumors in the rectum. They have a more aggressive biology, so the clear recommendation is to excise these tumors in any size. So even if it's only a few millimeters, it should be taken out completely. For any localized GIST, the clear recommendation is a complete surgical removal. Now, what is complete? Complete is complete. So the tumor is completely out. We have a clear margin completely around the tumor. There is no clear recommendation on the margins, whether it should be 1, 2, or 3 centimeters, but it has to be complete. So the whole GIST has to be surrounded by a layer of normal tissue. Then it's complete. What about lymph nodes? Removal of lymph nodes is not recommended because they are nearly never involved by the GIST. The only exception from this rule are the so-called pediatric GIST cases, predominantly in the stomach, in children. They sometimes involve the lymph nodes. So if a tumor like this is operated on and the lymph nodes look suspicious, it's recommended to take them out, but not in the way of a systemic lymphatic dissection, which is a clear rule in gastric cancer, in regular gastric cancer, but suspicious lymph nodes should be taken out in the rare cases of pediatric GIST. In case of big tumors, and big is relative to the location, this means any tumor where a shrinkage would lead to a less mutilating surgery. This means big tumor in the stomach, if the surgeon says, well, there is a risk that the whole stomach has to be removed. In such a situation, the very, very clear recommendation from any guideline is to offer preoperative systemic therapy to shrink the tumor and allow for a less aggressive surgery. In all of these cases, clearly, a mutational analysis is absolutely mandatory. So that is not some sort of luxury you can do or leave it. It's clearly mandatory, and this approach should not be followed without a mutational analysis. This is showing a picture of a rectal GIST. Obviously, the tumor, very big. You can see it on the left side. Obviously, this tumor could be resected, but at the cost of a permanent artificial anus. So in such a situation, we offer preoperative systemic therapy with Imatinib after doing mutation analysis and checking for a sensitive mutation and checking for the correct dose of Imatinib, 400, or in case of exon 9, 800. Then we treat the patient for at least 6 months. Sometimes it may be also a year until maximum shrinkage. And then the tumor can be resected much more easy. And in many cases, a mutilating surgery can be avoided. So in any case where the surgeon suggests aggressive surgery, patients should get a second opinion and check for a preoperative systemic therapy to allow for less aggressive surgery. In case we do preoperative systemic therapy, this will be taken into account after surgery when we think about postoperative adjuvant therapy. We'll come to this in a few minutes. Now, what about the risk of recurrence after surgery alone? This is showing the pooled data from 10 population-based GIST series. So that is a very big number of patients. And this is showing what happens to the patients after surgery for a localized GIST. Keep in mind, this is pooled data from any type of GIST. Big ones, small ones, high mitotic count, low mitotic count, the overall population of GIST. And as you can see, approximately 60%, more than half of the patients, will be cured after their surgical procedure. Now, the question is, of course, and that's what the patients want to know and what we doctors want to know, the patient sitting in front of me, does he belong to the group of 60% who has already been cured? So there is no need to do anything more. Or is the patient unfortunately belonging to the 40% who are likely to develop a recurrence or a metastatic disease? These patients I would consider for additional treatment. So is there any way to discriminate between those already cured and those at a high risk of recurrence? And the answer is yes. There is a couple of methods to discriminate these patients. One of the earlier risk assessment systems is the one from the Armed Forces Institute of Pathology, abbreviation AFIP, and they came up with a risk group classification published in 2006, so quite a few years ago, using very simple instruments, namely the localization, gastric, jejunal, small bowel, duodenal, or rectum, the size of the tumor in categories of less or equal than 2 centimeters, between 2 and 5, between 5 and 10, and more than 10. And also 2 categories for the mitotic count in high power fields, less than 5 per 50 or equal to 5 than 50. So anything below 5, but including 5, or more than 5, so 6 and above. And with these informations, size, mitotic count, and localization, we can estimate the risk that the patient will eventually develop a recurrence. And recurrence is mostly the development of metastatic disease, and in rare cases, the development of a local recurrence. But the problem is the metastatic disease, liver metastases, and peritoneal metastases. And as you can see, the risk is in a very, very broad range. Those with a small tumor and a low mitotic count has a virtually inexistent risk of recurrence. It's nil in all 4 localizations. Maximum are the big tumors, more than 10 centimeters, more than 5 mitosis in gastric and small bowel location. So that is a group of patients who have an extremely high risk of developing metastatic disease, and development of metastatic disease mostly takes place in the first 2 years after surgery. There are eventually late recurrences, but most patients develop their recurrence within 2 years after surgery. So if we use this, we can tell the patient, well, your risk is quite low or your risk is rather high. The problem with this system is that, and that accounts for anything, we have very sharp cutoffs. That is, if you drive too fast, there is a cutoff when the police will get you by a picture. And if you would have been driving a little bit less, maybe 1 kilometer per hour less, there would not have been a picture, no fine, no payment, no driver's license lost and things like that. So there is a cutoff, and you might argue, well, 1 kilometer more or less, that cannot eventually lead to loss of driver's license or not, but that is the rules. There is a cutoff, and that makes things on one side very easy because it's simply yes or no. On the other hand, it's of course a little bit tricky because losing the driver's license is something, but deciding on a 3-year treatment, yes or no, is something else. So a few examples. If we take a look here, we have a gastric cyst. And the pathologist says, well, it's clearly more than 5 mitosis per 50 high power fields. So let's say it's 9 or 10 mitosis. But the size is a little bit questionable. So the pathologist says, well, it's around 5 centimeters. Now imagine a resected surgical specimen. That is obviously something quite soft, and you put it on a plate, and then you take a ruler and you make a measurement. And whether the pathologist makes a measurement of 5 centimeters, then the risk for this tumor to recur would be 16%. That is what we call intermediate, and we would not necessarily tell the patient that there is a risk high enough to justify adjuvant therapy. However, if the pathologist takes a measurement and says, well, it's 1 millimeter more, 5.1 centimeters, and this is extremely difficult even to distinguish between 5 and 5.1. However, if the pathologist says, I call this 5.1, then the risk would be 55%, which is a high risk and obviously an indication for adjuvant therapy. So we all would agree that the difference between 5 and 5.1 centimeters would never echo a difference between 16 or 55%. It's simply that one is the group below and one is the group above, and where the group meets in the middle, we have an area of uncertainty. The same actually happens with a mitosis. If we take a tumor between 5 and 10 centimeters, again, gastric cyst, let's say 7 centimeters, then if it's any mitotic count below or equal to 5, so 0, 1, 2, 3, 4, 5, or more than 5, let's say 6, that makes, again, a very big difference. If the pathologist says 5, then the risk is 3.6%. That is a very low risk, nothing to do, not even clear indication for regular follow-up. However, if the pathologist counts 1 extra mitosis, the risk goes up to 55%, and again, high risk indication for adjuvant therapy. So you can see things are a little bit complicated, and if you ask 3 pathologists, you will get 5 different measurements. So it's not trivial. What can we do to avoid this problem? Our friend and colleague Heikki Joensuu has developed a slightly different system called the prognostic contour maps. And the big difference here is that in this system, we do not use categories from 2 to 5, 5 to 10, more than 10, but we can enter any measurement, any mitotic figure in numbers, and we will come up with a system that represents the biological continuum. So the difference between 2 and 3 is there, and the difference between 7 and 8 is also there, but it's not a big step from one to the next point, but it's a slight or a little bit more increase, but it's a continuous system. And that led to these contour maps where we do not have steps, but we have changes in color, and the colors represent the risk categories, not exact figures, but ranges for the specific patient's risk. Also, in this system, the important information on tumor rupture has been included. So there's 3 options. Either we know that there is no rupture, or we do know that there is a rupture, or there is a questionable rupture. That is a very rare situation because normally you can say yes or no. But in case you are not sure, you can use the upper row, which is uncertainty on rupture. Now let's assume we again are talking about a gastric cyst. That is the first row. We know there is no rupture, so it's the middle picture. Now we use the lower scale and we enter the tumor size. Let's say we have 8 centimeters. And now we look for the mitosis. And if it's, let's say, 3 mitosis in 8 centimeters, we have the median blue color. So the median blue color, we go to this category. The median blue color is between 10 and 20%. So this patient has a risk of 10 to 20%. This is still a low risk and does not justify adjuvant therapy. So by using this system, we avoid the sharp steps and a big difference by 1 mitosis or 1 millimeter, but we get a much better picture. My personal recommendation and approach is that I recommend to do, and I personally do, use both systems to combine it and to come up with a very good idea of the individual patient's risk of recurrence. Now we come to the available clinical data on adjuvant therapy of GIST. As we just discussed, there is a group of patients who have a high risk of recurrence. And if the risk of recurrence is high, the question, of course, is can we do anything to lower the risk of recurrence? If the risk is very low anyway, it's very unlikely that it can be even smaller. But if it's high, we can try to make it less high or even low if it works excellently. The first clinical study that was initiated to look at this was started in the United States. The study called C9001. And this study had a very poor design given the time when it was started. And we did not yet know all that. We already know, we do know about GIST today. So the criteria for entering this study was very simple. GIST resected more than 3 centimeters. That's all. And if you would go back in the 2 table systems or category systems we just discussed, you will find a lot of patients in a very low risk category, which means in this American study, many patients were treated completely useless because they had a very low risk and there was no chance to lower the risk because it was very low anyway. That is due to the very poor inclusion criteria. Nevertheless, that's the data published first in 2009, as you can see. And if we look at the overall survival, this is interesting in 2 ways. First, For the first 4 years, basically all patients survived. Nobody died in this group. And there was absolutely no difference between the 1 year of Imatinib or no Imatinib. Keep in mind, the treatment was either 1 year or nothing. 1 compared to nothing. That was the comparison. And for overall survival, there was no difference. Now, this is many years ago, but unfortunately, and this is sort of difficult to accept for the scientific community, this study has never officially been updated. We do not have any officially published data on long-term follow-up of these patients. So if we go back, recurrence-free survival, what happened to these patients? The longest follow-up here is 4 years, but what happened to these patients in the next 5 years? This has never been studied and never been published. That is something we are really not very happy, and also our American friends are not very happy about this, but they never managed to get the long-term follow-up data. We'll come back to this near the end of my presentation. Now, if we look at the mutational status as an important factor for risk of recurrence, we do see a lot of very important informations. First of all, exon 11, that is a very aggressive type of GIST, but also the GIST with the highest sensitivity to Imatinib. This means twice. First, patients who are not receiving adjuvant therapy, we would expect a lot of recurrences because that's aggressive GIST. But with Imatinib, which works best in exon 11, we would expect a big difference. And that is exactly what you see. In the first 12 months, that's the light blue bar, there was basically no recurrence, virtually a single one or so, but that may have been a patient who stopped taking his or her medication. Those patients not receiving adjuvant therapy, you can see there is a drop by more than 20% in the first 2 years. So more than 20% developed a recurrence within the first year with exon 11. If we look for the so-called wild type, it was called wild type in the old days. Now we call it no mutation in the KIT and no mutation in the PDGF receptor alpha gene. For those GIST, today we know Imatinib does not make any sense. It doesn't work. And this is already shown here many years ago. There is absolutely no difference, which is expected because Imatinib does not work at all. So the two curves overlap, no difference. Next issue, exon 9, very small number of patients. Again, no difference. Our explanation is that 400 milligrams of Imatinib is not enough in exon 9 patients. So they get some treatment, but insufficient treatment, and therefore there is no significant difference between treatment with the wrong dose and no treatment at all. Finally, PDGF receptor alpha. If we look at the lower image, that is the subgroup with the D842V. That is a mutation that is completely resistant to Imatinib, and therefore we do not expect to see a difference, which is the case. There is no difference. On the other hand, and that is another very important information, GIST with D842V mutation are normally very indolent. Indolent means they are growing very slowly. They only rarely result in metastatic disease, so they are somewhat less dangerous than, for example, exon 11 GIST, and therefore both curves are very stable near the 100%. So these patients do not develop a lot of recurrences, and Imatinib is completely useless and should never be offered to these patients. The next study, which is actually the most important study ever done in adjuvant treatment of GIST was the Scandinavian German study. This was designed by Heikki Uensu from Finland and myself. We entered 400 patients into this study. The majority, basically 100, 1/4 of these patients was included by my team in Berlin. Now we had a completely different question. Keep in mind, the American study included any GIST with more than 3 centimeters, which is a mixture of very low, low, intermediate, and high risk, but majority was in the lower risk group. And everybody received Imatinib, but just for 1 year, or the other by randomization group received placebo. So not everybody received Imatinib, but just half received Imatinib. The other half had placebo. Now our considerations were somewhat different. We at that time point were absolutely convinced that patients with a high risk of recurrence do clearly need adjuvant Imatinib. So our question was not Imatinib, yes or no. Our question was, of course, Imatinib, but how long? And the second big difference is we only included patients in this study with a high risk of recurrence, because even when we designed the study a long time ago, we were absolutely sure that those with the low risk of recurrence do not need any treatment, but those with a high risk do need treatment. So we included only high-risk patients. Everybody received Imatinib, one group for 1 year. That is the so-called historical standard from the American study. And the other group received Imatinib for 3 years, because the question was, maybe longer treatment is better than shorter treatment. That was not known at that time point, but that was the question and obviously the assumption under which we started the study. The first publication was made in the year 2012, and we had the late-breaking abstract #1 in the ASCO plenary session. That is the best place you can get for presenting new data in any conference around the world per year. That is the #1 starting place. And Heikki Uensu presented these data. As expected, there was a big significant difference in recurrence-free survival. Those with longer treatment had much better recurrence-free survival than those with shorter treatment of just 12 months. Now, interestingly, and that made the very big difference, also the overall survival was significantly different. Those patients with treatment over 3 years had a higher chance of long-term survival compared to those treated with just 1 year of Imatinib. That was a very striking thing. That was fantastic new information, and that created the global gold standard of care for adjuvant therapy of high-risk GIST. Starting in mid-2012, the global recommendation was to treat patients with high-risk GIST with 3 years of Imatinib when they as an adjuvant treatment. However, we'll come back to this a little later. As you can see, the curve stops at 6 years. So at that time point, 2012, the maximum follow-up was 6 years, and the majority of patients had a follow-up of less than 5 years. So that is already a meaningful follow-up, but the question remained, what happens with a longer follow-up? We then also took a look on the underlying mutations, and we could confirm what was already well known by that time. that the patients with a D842V mutation, shown here with a dotted line, they have a very good prognosis. There is very rare recurrences, less than 20%. So that confirms the rather indolent disease. They are not so aggressive and they rarely produce metastatic disease. The KIT exon 11, the yellow curve, that is the group with aggressive GIST. And there are, of course, recurrences. Exon 9 is the worst subgroup in this table. And the explanation here is those patients also received 400 milligrams of Imatinib. And I am personally convinced that this is not good enough. And they might have done better with 800 milligrams. What is our personal recommendation? However, there is no proof, but we think 400 is not good enough. We recommend higher doses. I already mentioned the question of follow-up. So what we did in the year 2016, we presented our study with a longer follow-up. Now the follow-up is reaching up to 9 years. So that is an additional 4 years. And this gives an answer what happens in the next 4 years of follow-up. As you can see, the recurrence-free survival, there remains a significant difference. The curves do not merge. And of course, much more important, the overall survival curve also did not merge. The curves stay separated. There is still a difference between those treated for 3 years and those treated for 1 year. Now, why is that so important? When we first published our study in 2012, many colleagues around the world argued, well, wait a couple more years of follow-up, then there will be no difference left. This is a contemporary effect, but eventually you will lose the difference, you will lose the significance. And we always said, well, just wait a couple more years, we'll keep an eye on that. And that's what we did. There was a third study on adjuvant therapy, which again, I mean, all those authors are very good friends of myself. However, I was not really in favor of this design of the study for a couple of reasons. First of all, this study included patients with intermediate risk and patients with high risk. We personally are convinced that intermediate risk is quite low, so we would not treat these patients. We prefer to treat predominantly high-risk patients. So that is one issue. However, that was not known years ago. We know now. Second, patients received either no treatment or 2 years of therapy. So somewhat in between. The Americans used no or 1 year. We used 1 or 3. And the EORTC study, in which we took part as well, we contributed patients to this study as well, was no treatment or 2 years, somewhat in between. The final issue is the endpoint of the study. The endpoint of the study was not the recurrence-free survival, which is measured from surgery to eventual recurrence, and not the overall survival, which is time from surgery to death due to any reason, but the endpoint was time to definite failure to the first tyrosine kinase inhibitor. That means patients who receive adjuvant therapy with Imatinib. It stopped after 2 years, or patients are randomized to no treatment at all. Some of these patients will develop a recurrence. On recurrence, the recommended first-line treatment is again Imatinib. If the recurrence develops not while under treatment, then it's a refractory disease, but if it develops after stopping adjuvant therapy. So if a patient had 2 years of adjuvant therapy, had 1 year off treatment and then develops a recurrence, the decision is to restart Imatinib. And the time to definite failure is the time until Imatinib now started on the first recurrence. The patient develops refractory disease and is, let's say, switched to Sunitinib. That point, switching to Sunitinib, is the time to definite failure. So that's the end point. Now the problem is that in this study, some patients on their recurrence were put on a clinical trial with Nilotinib. So they never received Imatinib as the first treatment of recurrent disease. So these patients were then counted failure of Imatinib at the time of recurrence, which is obviously much shorter than if they would have restarted Imatinib. Some patients on recurrence were immediately started on Sunitinib and so on. So there's a couple of issues why the analysis of this study is somewhat a little bit difficult. If we take the overall results, there is no significant advantage for 2 years of Imatinib over no treatment at all for the overall group, intermediate risk and high risk. There is a trend towards better in the lower graph for the high risk subgroup, but that is also not significant. So a little bit different in the results and a little bit difficult to analyze due to the issues I just discussed. So basically, this study does not really add to our knowledge on adjuvant therapy. The most important knowledge on adjuvant therapy comes from the Scandinavian German study already mentioned. Now, is this the end of the story? Clearly not. We do know today that 3 years is clearly significantly better than 1 year in high risk of recurrence patients. However, we do not know whether 3 years is the ideal duration or whether an even longer duration would be better. Now, some of our colleagues argue that in a high risk of recurrence, they recommended more than 3 years. The question is, what do you mean with more than 3 years? Well, some say, well, we continue a little bit longer, maybe a year or 2. Some patients would have preferred to have even longer duration, but that is something very difficult. So our clear recommendation is the current gold standard is a treatment for 3 years in high-risk GIST. Anything beyond 3 years is a scientific question, an issue for a randomized clinical trial. And there are currently 2 randomized trials going on in Europe, one in France and one in Scandinavia, United Kingdom, Netherlands, Germany, Austria, Spain. Unfortunately, not Italy, and obviously not France because they have their own study. And the question here is longer treatment compared to the current gold standard of 3 years. The randomization, however, takes place after 3 years, not at the very beginning. So we do not randomize 3 years compared to 5 years, but after the 3-year duration, we randomize an additional 2 years compared to control. Of course, in the end, it will be 5 compared to 3. This trial is ongoing in the countries I already mentioned. It's a little bit difficult to recruit the patients. However, we strongly recommend all patients in all participating countries to try to enter the study if it's feasible for them and if they have a risk of recurrence that qualifies for inclusion in this study. We need to answer the question whether 5 years are better than 3, because outside this randomized question and results from this study, we cannot give a recommendation to use more than 3 years. We do not have a scientific rationale to use more than 3 years. We may have a feeling, but that is not a scientific proof, so the study is extremely important. Coming back for the last couple of slides to the question of long-term follow-up. I did show our first study analysis with less than 5 years of follow-up. I already did show the prolonged follow-up with some 8 years, and I will now show you the long-term follow-up of the same study, because that is eventually probably the final answer to this question. What is the justification for the third analysis? It is still, now it's known, but prior to this analysis, it was still unknown whether the overall survival benefit remains stable after extended follow-up. It might have been that the difference gets lost after 10 years. That was an open question. Second, the question of long-term safety of adjuvant Imatinib. Of course, safety is even more important in those patients who take Imatinib for some time and then are likely to be cured. Of course, we want to be sure that there are no difficult long-term side effects, that they develop something difficult after 6, 8, 10 years. This we want to know. So we made an amendment to the study protocol to allow for the third and late final analysis of the study. That is showing how the patients were included in the study. I want to point out just one single issue, the difference between the intention to treat analysis. Intention to treat means you analyze all patients who were initially intended to be entered in the study. Some of these patients were later on excluded because the central pathology review did not confirm the diagnosis GIST, and it doesn't make sense to treat the patients with Imatinib in this study if they have a sarcoma, not GIST. So they were excluded, but they are still in the initial intention to treat analysis. We also excluded patients from the final efficacy population if they did not give their informed consent or if they withdraw their informed consent, so they never were entered in the study or they left the study. So starting with 400 patients on an intention to treat basis, we ended up with 181 in the efficacy population in one arm and 177 in the other arm. That is important to know, and I will show you the results in a second. That is the recurrence-free survival on intention to treat analysis. So that's all 400 patients entered in the study, even those who did not have GIST or who did not start their adjuvant Imatinib or did withdraw their consent. As you can see, even with this very long follow-up, there is still a highly significant difference. The p-value, which gives the level of significance, is 0.003, and the hazard ratio, that is the relative risk reduction, is 0.66, which is very high. Looking at the real figures after 10 years, you can see that with 3 years of adjuvant Imatinib, 53% of patients were free of recurrence, more than half, whereas out of those patients who had only 1 year of adjuvant Imatinib, just 42% were still free from recurrence. So there is a difference of 11% who developed a recurrence with 1 year compared to 3 years of adjuvant therapy. Now, the $1 million question is the long-term overall survival, and that is shown here. And the extremely important and confirming finding is the difference in overall survival does not get smaller over time. That is, if the curves would approach and get nearer, but as you can see, they do even divide more. The separation gets bigger, and after 10 years, the probability of surviving is 79% with 3 years of Imatinib compared to 65% with 1 year of Imatinib. So the difference is 14%, which is extremely important, extremely big difference. If we look at the efficacy population, though, so that is the real target population. That is patients who really had a GIST. That is patients who really remained on the study and who started and took their Imatinib. And the most important figure here is the hazard ratio for the overall survival of 0.05. Hazard ratio is the relative risk reduction. So that means after 10 years of follow-up, the probability of still living after having had a surgery of a high-risk GIST, the probability of living is double with 3 years of Imatinib, adjuvant Imatinib, compared to 1 year. So the risk of dying is cut by half with 3 years compared to 1 year. So that is the final confirmation that 3 years is the gold standard of treatment for high-risk GIST outside of a clinical study, looking for an even longer duration. So I will skip this. That is the conclusion, which I already explained, with a 50% reduction of risk dying from the GIST. So final slide, summary. Before we decide on adjuvant Imatinib, yes or no, we do need to make an evaluation of the risk of recurrence. My recommendation is to use different systems and take them together to get a best possible idea of the risk of recurrence, but not doing a risk evaluation, that is not allowed. That is forbidden. If somebody does not offer a risk evaluation, you need to see somebody else. Imatinib 400 milligrams is the gold standard for a duration of 3 years in case of a significant high risk of recurrence. My personal recommendation is to try to use higher doses in rare cases with exon 9. There is no global consensus on the dosing in adjuvant therapy of exon 9, but the majority would tend to recommend higher doses in exon 9. There is a very clear recommendation that no adjuvant therapy should be offered in low-risk patients. That does not make any sense at all. Mutation analysis is absolutely mandatory. Again, already mentioned in the beginning, that is not a luxury, that is mandatory. No mutation analysis, no final decision on adjuvant therapy. Clearly, no adjuvant therapy in PDGF receptor alpha exon 18 D842V mutation. Most patients with this mutation do not need adjuvant therapy, and even if they would need it, Imatinib does not help, doesn't work in this disease. And also, clear recommendation, no adjuvant therapy in KIT, PDGF receptor alpha, not mutated GIST, so-called in the old days wild type. These patients should not be treated with adjuvant Imatinib as well. So that concludes my presentation. Thank you very much. And again, I would have loved to have a personal interaction answering all your questions, but I would say hopefully next year. So stay healthy, everybody. Thanks and bye-bye.